Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with the group. They're running a AEC course in Norway, as I understand it. How are you guys doing?
Good, thank you.
Yeah, excellent. Yeah, it's starting to snow, finally.
Very good.
Location, great location. It's a pity we can't turn the picture around so you can see the lakeshore. It's fantastic.
Perfect. So if you guys would you mind doing a quick introduction? Just go down the row.
Yeah, hey, I'm off camera. This is Sean. I've done some podcasts with you before, and obviously one of your colleagues, Dennis, so good to be here. And I rounded up these guys because I think they've got far more interesting things to say than I, so thank you.
Perfect.
Tim Cranton, I'm a faculty member of the College of Remote and Offshore Medicine. Here actually as an instructor candidate, and we're hoping that we're going to be able to spread the word and do AEC training in Malta, where we're based.
Nice. Tim, what's your background?
Background, ex-military, British Army, paramedic, fire rescue, and I'm actually working as an offshore medic and remote healthcare practitioner at this moment in time. So oil rigs, boats, ships, etc.
Perfect. Abrick, I remember you.
Howard Hicks. My name is Averick O'Kelly. I started the College of Remote and Offshore Medicine. My background is 1st Special Forces Group and then 3rd Special Forces Group before that, before emigrating, marrying a local and emigrating to this side of the pond.
Very good. Tom?
Yeah, hello. So my name's Tom Mallinson. I am a paramedic and family medicine doctor and pre-hospital medicine doctor based in Scotland, doing a mix of urgent care, pre-hospital care, and a few other bits and bobs. And I am also a lecturer with Coram, which is why I'm here. And that's mostly it.
Perfect. So, Coram, I'm been into their master's austere critical care course, which I really enjoy it. But you're teaching AEC. So what exactly is that?
But I think Sean could probably say austere emergency care course.
Yeah, he's the background.
He's the yolk that made it.
So when we started the whole, the prolonged field care effort, there was a lot of questions about how to teach it. And so a few of us developed over the last few years a curriculum that could be delivered in a 40-hour continuing education format. And it's essentially designed for civilian and international audiences. And so really piloted that with multiple U.S. audiences here in 2022. And now that we've formalized the curriculum, we're getting out there and we're introducing it to other environments. And so we were, Coram was kind enough to invite us over to, they're hosting the course. And so helping to mentor with the course and get it started here in Europe.
Perfect. So at this course in Norway, what kind of students do they have? You mentioned civilians, so.
We have civilians, some who have been prior military, but predominantly civilians. They are working on civilian EMS. They're working in a very remote civilian areas, such as upcountry Norway, in the middle of nowhere. And they were finding that they needed the prolonged field care guidelines, and they've been using them. So pretty much everyone in the class has been on the PFC website and is implementing the learning and training of PFC.
Yeah, perfect. So I would imagine farther north, more like oil rigs and mining type things. Is that kind of the common thread up there?
Yeah, there's two guys that are on the course. One of them, actually very similar to myself, works in an offshore environment on rigs. So again, far away from shore and limited resources. And the main thing really, certainly for us, we have quite a lot in common, obviously. And we've got everything we need, but we're just not going to be getting rid of the patient when we want to get rid of them. There's no, 20 minutes and an ambulance will come and take your patient away. It's 3, 4, 5 hours longer on a good day before we're likely to be able to evacuate a patient. The nice thing, certainly for this guy, is his environment is a little bit different from mine, so we're obviously able to learn stuff off each other. But he actually has within his same company, because there's two of them, his partner is an anaesthetist who is one of the kind of medical directors of the organization that they're with. So for him, it's a good appreciation of the environment that his paramedic is in, so that when they're talking to each other, so when they have the telemed call, the doc needs an update on the patient, etc., he has a good appreciation of the environment that he's having to carry out his care in. But I think we've got some ex-military guys that already have experience in prolonged casualty care, prolonged field care, but now they're moving from the military kind of into the civilian sector and realizing that it's taking longer to get patients from point of injury to definitive care. Prolonged care is a necessity, certainly the knowledge of it and how to go about it.
And there's been some really good opportunities there so thinking around those capabilities and minimum better best standards, firstly there's commonality of the issues we all face in the different levels, whether that's you're on a Scottish island and the helicopter can't get to you, you're on a rig, you're deployed and then people can't get to you for other reasons. But there's that commonality there, and the course brings that commonality together, but then also feeds off the differences. So you end up with all these really experienced clinicians who are working in different areas who have similar challenges and are overcoming those challenges either in very similar ways or in very different ways. Mm-hmm. So you can talk about different approaches to analgesia, different approaches to hypothermia management. And because it's a course of experienced clinicians, you have a massive amount of cross-pollination compared to a course that's turn up, we're going to teach you a skill, and then we're going to tick a box that we've taught you a skill. This is very much not that course, but it's changing people's mindsets and exploring how they're muddling through that austere environment in their different austere environments, and then providing a guideline under kind of prolonged field care and the CPGs for this is what we think is the best current evidence for doing that, and then saying, how can you do that on your rig, on your island, in the backcountry?
For some of these guys, they work up in the north, so they're in kind of rural areas. And it's not necessarily distance from definitive care. It may actually be the whole reason why they can't get their patient there is because the weather is so bad. And there is no way to get a wheel-based platform, to them, or a fixed wing or a rotary wing. Mm. They just have to sit on the patient until the weather clears, or there is an opportunity to be able to get a snowplow through, to be able to get access, and then bring the patients back that way. So the only reason they're sitting on the patient is because the environment dictates that's what they have to do. So it varies. It's not just about distance. It could also be about the environmental conditions as well.
Yeah. It's a really nice mix of participants, which I think was your question.
Yes.
that we led off.
They're from all over Europe. They're just not Norwegians.
Okay. Perfect. So, in your guys' experience teaching, is this the first time you've taught a civilian AEC course in Europe?
That's correct. We are the first.
Okay, perfect. How is the 10 core capabilities that we talk about for the military? How is that translating over to the civilian providers?
Well, so I think for a lot of the participants, they'd already read it. They knew about prolonged field care. They knew about the website. They knew about the guidance. They knew about the 10 or 12 capabilities, and I think had an appreciation of the benefit of that. Mm-hmm. And then we very kindly facilitated. We had a great discussion around those, and I think they already had an appreciation of them. But then we're pushing that appreciation and finding areas they're finding their own areas to improve capabilities that they aren't doing as they're not providing best. And that's what I've been reflecting on in my practice. You think, oh yeah, that capability, I think I've got it nailed. And you hear what other people are doing, and you think, oh, we're not really providing best there, are we? We're providing it's better than nothing. It's okay.
But one of the exercises in the class was kind of a needs analysis. So we give them their kind of minimum, better, best sheets and capabilities, and we kind of go around and say, right, in your environment where you find yourself and you work, what do you think you have? And it's kind of a really good exercise, because looking at yourself and actually looking what you have may actually, you realize, wow, I have, I could do better than this. Or maybe I can improve, or this is a way I can go back and think how I can provide a better or higher level of care. But also at the same time, utilizing the resources that they already have in such a way that they can maybe upgrade or downgrade. But as I said, the nice thing about the course is it includes looking at their current situation and then having a greater understanding, so that when they go back, they can make improvements.
So I get, as a very, very specific example, which isn't really what the course is about. The course is about, I think, a change of mindset rather than specific how-tos. Today was included a discussion of ketamine as an infusion and how to do that safely, appropriately, how to not waste your ketamine in the acute phase and how to stretch it further, but in a safe and controlled way. And I think that was great, because loads of the people on the team we're ketamine users, we're happy with it, we use it weekly on a daily basis, but then turning it around and saying, but what if you only had 2 vials? And now you make it last, and you want to make it last in the best way, rather than, I'll top them up. What about if someone had actually done the legwork behind that and worked out how to safely, effectively provide that as a longer intervention, which is a very narrow example of the whole course, which is, we can all manage a trauma patient for 10 minutes, for half an hour. But what if you have to have very similar resources and do it for 3 hours, 8 hours, 2 days? Which is the question loads of us are posed in our practice. But this course gets you thinking about it and starts to nudge you towards sensible, thought-out solutions rather than improvised solutions, which has its place. Improvised medicine has its place, but it's nice having someone who's just fixing those problems ahead of time for you.
One of the exercises we did today, we were looking at nursing care, and we were looking at urine output. So what goes in must come out. And how would we manage that if we don't have a catheterization pack? And we had literally a couple of guys made Uridoms out of glove, out of a tape, out of some tubing, as a means of being able to keep a patient in a position where, he can stay stable, but at the same time he can still carry out his bodily functions. Right. And it was a question of, we didn't tell them how to do that. It was, okay, guys, look, we need to measure what goes in, what comes out. There are certain things we want to check. How are we going to manage that? How are you going to manage that? Right. So it's not just, like you said, it's not just us telling people. It's what do you think, guys? If you don't have this, how are we going to fix this?
Someone did suggest the same jug for input and output, which was frowned on by other participants. But that would be an accurate measure, wouldn't it?
It would.
A litre in, a litre out, a litre in, not the same litre.
I would hope not.
Yeah, it's that change of mindset.
But it's creating group discussion as well, which is important.
Yeah.
You notice the first day of any course, there are individuals sat at a desk. Yeah. The idea being that by the end of the first day, we want those individuals to be a team. And we put quite an emphasis, I think, on the team approach. Mm-hmm. And there is no one expert in this particular room. We've got a couple of nurses, and especially today when we're talking about nursing care, they're the kind of go-to. So this is what I think in my environment, but what about you guys? How would you manage it? And these are the experts in terms of their direct relationship with the patient, understanding the patient's needs, and not necessarily calling them a casualty, a patient, but addressing them as a person and treating them that way. And that personal approach, I think, also makes a difference. So the likes of the docs maybe are used to, you can give those meds, go ahead. Or they're used to giving the orders, but not interacting with the patient. Whereas now, we're saying, okay, you group of guys, doesn't matter who you are, where you come from, you need to turn this patient. We need to start nursing care procedures. You're all part of this process, and very much adapting that team approach, regardless of who you are or where you come from.
Yeah, and I definitely see in the courses I teach, you get a bunch of individuals at first. Everybody has their strengths and weaknesses, and just getting kind of over that hump of, getting behind those defenses that everybody puts up on the first day. Just open up. Everybody has, things that they're good at, things that they're not so great at. So, you have to be able to expose the things that they're not great at so that we can all move forward, And like you mentioned, like the ketamine drips and things like that. In the course that I run, we use real drugs on real patients. And that's when everybody really finds out how good their plan actually was. Because, they're burning through their ketamine faster than, they thought anyway. And they're forced to have to use other drugs that they were not comfortable at all with, But that's another great thing is just going through that thought exercise of you have these 2 vials of ketamine for, an indeterminate really period of time. How long can you make this last?
Yeah.
And actually take care of the patient. How long do you actually need them to be sedated? How long do you actually just need pain control? And how do you adjust their dosings to achieve those goals? And how does a patient change when you've taken them from conscious to unconscious and sedated with ketamine? And how do you wake them up properly?
Do you need to be good at math, though, Tom?
No. So one of the things we are experiencing is this is not our course. So we instruct candidates.
Well, I should say for the record, do you know who came up with that drip calculation, right?
No.
Yeah. He's the one who put it in there personally. So you can thank him for math in public.
Who's that?
Thomas Kirsten. No, you came up with the drip calculation and showed it to some of us, how to make a drip calculation from scratch, the drips.
Yes.
And Tom was cursing your name all during the lunch break as we were trying
That's
to.
okay.
He didn't know
That's okay.
it, but I thought I would call that out right now. So, yeah.
So
That's
again,
okay.
it's very, very useful having that in the course because you're saying we're not doing something maverick here. This is the working. This is why we know what we're doing is sensible. But trying to do math in public, that is not on my list of to-dos. That's unpleasant.
Yes.
Yeah, thanks.
But that's okay. The instructor to be uncomfortable, the instructor to make a math mistake and then
Loads of those,
do it quick on I'm sure the students are really quick to point that out.
That was my style of learning that I was trying to get out from. I thought if they could identify the mistakes, they'd teach themselves.
Yes.
Yeah.
Yeah, that's perfect.
That's great. Thanks.
It's perfect. But,
we really discuss things. I don't want to say cheat sheets, but we've talked about checklists as well, especially when we're using the PFC, the charts. So for myself today, I was working with the care plans, so the 12-hour and the 24-hour care plans, and having those checklists. So I use an analogy, flying the patient. So in an emergency, we take our checklist up and we see what's wrong with number one engine, and we work through a series of things to find and fix that problem. And that very much transfers over to prolonged care in that we've got a nursing care checklist that we're able to follow. So we have a plan. So we have a direction that hopefully is to the benefit of the patient, but identifies a need to let someone know so that we have an idea what timescale we're working with. Then you know how long your drugs are going to, or potentially how long you need to make your drugs last before we're able to offload the patient to the next level of care. So it all ties in. It all ties in. Yeah. Again, you're playing to the strengths and weaknesses of the team, because like I said to you earlier on today about the drug calcs. So, I've been through a course before way back in the day when I, started out doing my paramedic training, and it's something I always struggled with. But when you're working as a paramedic or, a doctor team in pre-hospital care or retrieval, that you play on each other's strengths and weaknesses. There's things I might be good at that maybe not so much Tom, and then vice versa. So I'm going to look at the doc and say, you know what? Yeah, I know what drug it is you want, but can you give me a hand with the math in front of the class?
We can't do maths. So we're going to have to find a third person.
We have plenty of
PhD
PhD in mathematics.
Oh, there you go.
But it's, again, it boils down to the team having a plan and working towards the plan.
Yeah, absolutely. You know, it just, a lot of it, I think, is just that thought exercise of just really getting to see the scope of things, like how much you have to get done. You know, what do you have to work with? You know, even the nursing care plan, yes, they whip out their cheat sheet and they look at, the 12 things that you need to get done. But actually putting that into practice and find out if you do individual tasks one at a time, you're going to be there forever. But if you gather all your gear together and find out I need to give, a bath, I need to turn the patient, I need to check their IV patency, I need to do oral care and, check, vital signs or something like that. Gather all your gear and you tackle the problem essentially in one big circle around the patient to actually achieve what needs to be done in an efficient manner. And, you're not one person isn't spending the entire hour doing an hourly task.
And I think that kind of stuff links right back to the capabilities, because you've got your nursing checklist or your, personal care checklist, patient care checklist. And I think it's very easy to think, I can do all that. I do all that for my patient. Yeah, I keep them warm. I put a blanket on him. What more does he want? But I think then if you've already been introduced and refreshed on the capabilities, you think, putting a blanket on someone, that's not the best I can do, is it? Like, I've done a crappy job there. That's not great. Or, like oral hygiene, you think, I've given him some water to wash his mouth out. You think, that's not the best. That's not the best we could be doing for that patient. So I think a lot of it links back to the capabilities, and I found that was a key way of changing my thought process, because rather than just thinking, am I ticking off these boxes, I'm thinking, am I doing the best for all these things? So I think that's like the nursing care is,
right.
Am I just doing it, or am I doing the best I can do for everything?
Right. And I think certainly coming from a kind of a special operations kind of background, usually the patient is one of your teammates.
Yep.
So you have a direct relationship with that person. You absolutely want to do the very best for that person. But I think for us in a civilian setting, we don't necessarily know this person. We could get deployed to Turkey or Syria as part of a humanitarian aid team, pull someone out of the rubble, as the British Army have done most recently. They've deployed, tented field hospital, and they're pulling out patients. They don't know their comorbidities, they don't know, the normal status of this person, and they're having to provide the best in inverted level of care, depending on what they literally have with them.
See, it's interesting you drawing that correlation, because I agree. I was a paramedic in London. When you're a paramedic in London, you don't know any of your patients. You rock up, you help someone, you leave, you never see them again, probably. But then when you move to rural practice, rural medicine, you know a vast majority of your patients. So I guess then it is much more akin to that small team. The small team might be your village.
Small community, yeah.
But it's a small community. So then you have that same pressure in rural practice, that you know the people you're seeing in clinic, and you're going to see them again. And if you mess up or don't do a good job for them, you're going to see them again, or you're going to see their parents or their children. So it's interesting that odd correlation and difference between urban, rural, and
as a rural GP, you could do a call out, go to someone's house. So you see that patient and you're like, I want this patient to go to hospital.
Yeah.
But unfortunately, as is the case in the UK at this moment in time, actually getting a patient admitted to hospital is a significant challenge.
Or you try to get them into hospital, and then 3 hours later you get a call back to the same house.
Right.
Because no ambulance has turned up yet.
So you're prolonged.
And you have prolonged field care, but you didn't realise you were going to be doing prolonged field care. You realised 3 hours later, when you thought they were going to have antibiotics an hour ago, you might have given them a dose, like their first stat dose, and then it's 3 hours later, and they're still at home, and they're still pretty sick.
Right.
And you're like, I'm doing prolonged field care, because no one's come to pick up my patient.
Right.
Which is a different...
But in terms of proximity to definitive care, you can't get any closer than the emergency department in an ambulance, waiting to discharge your ambulance into the ED, but they can't take you because the ED is full and over capacity. So you're
prolonged
10,
field care parks in the car park.
50 yards away from the emergency department
Yeah.
with a doc who's coming and doing the rounds of 15 or 20 ambulances that are queued up. And I had a call from a paramedic colleague the other day, and he waited 8 hours in the back of his truck, sitting on a patient who was very sick.
It helps if you don't sit on them.
Maybe that's where it was going wrong. So.
Really impairs ventilation.
Okay, I'll message him back.
You should
WhatsApp and get
note that down.
But you know, that's kind of an extreme because it's something you don't expect. We're in an urban setting where you think you have direct access, 20 minutes, ambulance arrives, picks the patient up, 10, 20-minute ride, discharged into the emergency room or wherever, or direct admission, and then we're away. But we're finding more and more globally that it's taking longer for all of our patients to get to definitive care.
Yeah.
It's not unique to people working offshore or people working in, living in rural or austere wilderness areas. This could be in the middle of a busy city.
Which is a big culture shift, isn't it?
Yeah.
Used to, I've got to take 10 minutes, I'll do the best I can, and then I'll hand them over.
Right.
And now that same clinician has got them for 3 hours. Even that 3 hours is prolonged care when you're planning for 10 minutes.
But I think it also highlights a need for training just like this.
Yeah.
Because certainly for myself, it's kind of weird as an offshore medic when I go and do my 3-yearly kind of refresher. They very much focus on our immediate care type courses and refreshers, advanced cardiac life support, ATLS, and we do our acute illness management. But they don't sit us on a patient for 6, 7, 8 longer hours.
Right.
The training scenarios are usually done in 10 minutes, and that's it. My personal opinion is we need this training as all healthcare practitioners, especially those working in a pre-hospital care setting.
You mentioned, your friend having to sit on a patient for 8 hours and how that is becoming more common. I mean, there's no natural disaster happening right now. So why is this starting to become the normal?
I think I think we've got a COVID, a relationship to COVID maybe somehow. Now that people are allowed out of their houses and back into the community, our emergency departments, certainly in the UK, I can't say that. I live in the Czech Republic, and I can't say that I get that in the Czech Republic. But in the UK, volume-wise, I don't know if you've experienced that more so, Tom.
Volume's an issue. Clearly, so we've currently got junior doctors' strikes in the UK. There is political and financial issues currently around staffing, amount of money going in. So I think we've created a perfect storm at the moment that's been building for a number of years, and I think it's some sort of post-COVID has brought that to a peak. But I think it's hugely multifactorial for the UK.
Yeah. Are other places in Europe facing kind of the similar situations? Or?
I mean, I live in the Czech Republic, and I'm not experiencing that where I am. And I mean, personally, the level of healthcare is, it's very good in terms of access. It's actually very much modelled, their healthcare system is very much modelled on the UK's NHS. But the dynamic is different, and I don't know if that's because of culture, being culturally different. But we certainly have remote healthcare because I have colleagues that work, again, mostly in rural areas. Or they may be, there's motorsports, a colleague of mine actually works in the motorsports area, but then they can't get road ambulance there. They usually have to get a flight there, and that could take a significant period of time. So they'll have to extricate on the track if there's a crash. Then they've got to ride the patient in an ambulance to their little clinic, and then they've got to sit on the patient in the clinic until such time as they can actually get someone with them to take them to a proper hospital with the capabilities that will match those patients' needs. So again, they can be there for several hours.
Yeah.
So again, it depends on the environment that you find yourself in. But I think generally speaking, we are identifying a shift towards the need for austere emergency care and a prolonged field care management.
A move towards having a patient for longer than you think you should have that patient where they should be somewhere else.
That sounds
Right.
good.
Due to whatever reason.
Yeah. think civilian medicine, we've kind of gotten used to being able to see a specialist very shortly for whatever our problems are, and that system isn't necessarily sustainable, especially, and this is just normal care. You know, throw on top of it some kind of, disaster, whether man-made or natural, it just quickly overwhelms the system because people are used to one level of care, and now that whole system is now stretched thin.
Yeah. I will just add really quickly, so where I am, rural Scotland, we do still have the opposite issue of the farmer who gets crushed by a cow and doesn't want to tell anyone because they've got to finish sorting out the cows. So we still have the super resilient Scots as well. So I think that is the global problem, but we still have the farmer red flag problem as well, which is, they're both problems.
Yeah, I mean, you're always going to have those people that they got cut up with barbed wire and they just put some Band-Aids on it and get back to work, and you ultimately find those people because they're dead or they're incredibly sick when they should have gone 2 or 3 days ago to the hospital. Now you get to deal with a crashing patient.
They went to the vet instead. Yeah. They were more concerned about the cow being hurt than themselves.
Yeah. While they were there, picked up a shot for them, shot for the cow.
Yeah.
So, I mean, even in just larger, European areas, very developed areas, having to deal with prolonged field care, even in cities, major cities like London, you mentioned. How does that, like some of the students that you have, working on oil rigs, like what is it like to be an austere medic or care provider on such a remote kind of outpost where maybe you have resources, but like you're it?
Yeah. So I mean, I work for Shell, huge oil and gas company.
Yeah.
But actually, the medical services provider is a company called United Health Global, well known in the US. And I am the sole medical or qualified medical person looking after a number of personnel on board that's can be between 150 to 200 people. Working a 24-hour shift, but that's 12 hours on and then 12 hours break. But at any time, there could be an accident or incident. But in the same respect, our industry is highly regulated in terms of risk assessment. You can't do a job unless you literally have written permission to be able to do that job, and all of the necessary safety measures and controls have been put in place to create as safe a working environment as possible. So arguably, a lot of my time is actually general healthcare and incident accident prevention. So actively going out to prevent disease and prevent injury. Because if we do get those issues, then obviously getting our patient to where ultimately they would need to be is going to be a significant challenge. So for my location, on best day, to get a rotary wing aircraft to our location is 3 hours. Best day. Patient may go to Stavanger, patient may go to Scotland. Nearest hospital is probably around an hour and a half away, but they would still have to be met by a ground ambulance and then still taken to the hospital. So Gilbert Vane in the Shetlands. But it's what if you get that really, really sick patient, the one that is really gonna press all the buttons in terms of their demands, compromised, circulation, compromised airway, compromised breathing. We do train our catering team because we have a chef. This is a hotel, it's an airport, it's a oil and gas refinery in the middle of the North Sea somewhere or some other part of the world. In which case we cross-train a lot of people in first response. So if I have an incident with a patient, I can do all of the invasive stuff, while some of the other guys can come in and do the basics. They can also make notes for me. So, literally a guy as a scribe can write interventions that we've carried out with times, etc. on a board, so that then I can take a snapshot, and at the earliest possible opportunity, that's
We're
our
still
lights
here.
gone out. We are still here.
Yeah.
Ocean lights.
It's working in a remote location. This is where I wish I'd had my head torch on. Or security just locked us in.
Ironically, it's because Norway is very advanced and everything's automatic. So
Anyway,
they stop detecting our heartbeats or something.
but sorry to carry on whilst we're working through our technical issue. Yeah, I've got somebody to scribe because there's an expectation from my organisation that before I would contact what we call our topside service, I have the ability to hand over that patient. We have a system called Medbase. So as a minimum, my primary assessment and the initial interventions I've made will be put into Medbase along with pictures of the patient so that Topside has a direct access to what I've done so far when I finally make that call. So I'm not having to run back to the patient to give them the observations. It's already there. And that's an expectation. Don't call Topside until you've prepared, done your initial telemed preparation so that you've got something to work from. And I'm not alone in a sense that I've got helpers, although they're not trained, let's say, medical people, they are trained to, I won't say as far as EMT, but they're first responders. They can do basic life support, so BLS responders. And then I've always got someone, actually Dr. Tom might be someone that may end up at the end of the phone. And he's going to help me, although he can't be there physically. He can certainly help me when it comes to my drug calculations and and the decision-making process. And then really, it's a question of, as soon as possible, secondary survey is done, and moving into my nursing care and prepping my patient and packaging for evacuation. And that's only going to be based on being told by the Coast Guard how long it's going to take for them to come out. What I tend to do is we have an installation manager. So if I have someone who's really sick, I call him to the sick bay. So whilst there's a kind of a patient in confidence, it's a little bit different in our setting. Other people need to know for the benefit of the patient. So if the installation manager can see someone writhing around who's really sick, they know this is not messing around. And when you work in an industry that questions everything you do in terms of cost, then obviously that's very motivational when it comes to installation manager, I need search and rescue. But then I have to have had that conversation with Topside, who is the one that ultimately says, yes, you can have SAR or no, and they will contact the Coast Guard on my behalf. But again, a perfect example the other day, I had a patient with an acute abdomen. Initially, I was asked to wait 4 hours, and then within an hour, I was asked to wait 6. And eventually, I think we got a search and rescue flight in 9 hours later, 3 o'clock in the morning. And then obviously SAR came in, picked him up. I did my full handover because I had the time to do it, but I just had to sit on the patient. And at the time, the patient was actually in a pretty good state because of the care that we'd given. Pain, he was more comfortable, he had some fluids, but he needed to go and get scans to try and rule out anything that was underlying. And he was in hospital, I think it was around 10, 11 hours after the initial incident. But if it was a resus, and we have an aging workforce, and it's happened, thankfully not on my installation recently, on my particular shift, but it has happened during the lifetime of the installation. And because you don't have those post-resus care abilities, the patients have not survived. And that's purely on the location and what we have. We could manage one patient, but God forbid we had an incident like kind of the Piper Alpha we tend to refer to, where there's a multiple casualty incident. That would be a significant challenge and not a thought really you would want to even think about until I guess that happened. We prep for major accidents and incidents, and we have a fire and rescue team on board, but that's only as good as our fixed firefighting systems. And I've certainly been on an installation on a vessel that's had a fire on board, and was partially destroyed by bad weather. And this was a floating production facility that had its firefighting capabilities were taken out when containers slid off its roof and took out one of our emergency fire pumps. So the environment dictates very much what we can and what we cannot do. And it can be a very lonely place if you have somebody who is sick, and I mean really sick. Routinely, coughs and colds. There may be infections, but again, I'll call topside, I'll call Tom, and we'll have a discussion. And if we can keep the patient there, we will. But if we can't get him back to work in the next 2-3 days, we'll usually get a routine flight and we'll take him off. But very much based on who you are, who you work with, and what you have. No one rig, I think, is the same in terms of its capabilities.
So you mentioned like their helpers, the support, other support staff. Do they already come trained, or do you have to train them?
So they come trained, but you need to give them more training.
Yeah.
It will be specific to that work environment. Some are keen to help, some not so keen.
Yeah.
Luckily, on my particular shift, I have guys that work with the Lifeboat Institute. So these guys may also be first responders in their own area, especially in the Highlands in Scotland. I have a couple of guys that actually do first response from home as part of an immediate care scheme. These are definitely guys, that's not the same everywhere, but that you definitely want to do your own training.
Okay.
Same thing with these guys to train each other.
Yeah.
Do you have any kind of like, I guess, knowing that somebody's, I'm guessing they're going to come with some kind of BLS certification. How far do you actually train them?
So I'm not going to train them to cannulate, but I'm most certainly going to train them to set up an IV and, be able to give me a bag of saline that's been properly run through so that it can be, connected up. Mm-hmm. I'm not necessarily going to ask them to prepare meds, but I may ask them to go to my medical bag and get that for me. So one of the things I might do is say, okay, guys, today's session, this is my crash bag. I want you to go through all of those things and let's put a name to all of those items. So it's not just me that knows the content. Yeah. They also know the content. So rather than me having to go and, move away from the patient, it's a little bit like the surgeon and saying scalpel.
Yeah.
They can hand me a piece of kit and that makes us just more efficient. And that's a little thing like that.
See, it's interesting because in my practice, often your helper is the police, right? Because the police get to the RTCs, the road traffic collisions, first, or as I get there. So I'm often playing the game of, can you go and get the red pouch out of the boot of my car, please? Can you hold this patient's arm because I'm about to cut a hole in their chest? And I don't get the luxury of training the police. Mm-hmm. They just have to. They have to trust that I'm a genuine doctor and just help me with whatever's going on. It's like
the paper airplane exercise.
Oh yeah.
I don't know if you want to mention that, but that was really good because it's relevant if you relate those two together, having to verbally explain what to do when you've got somebody who's untrained. I mean, I wouldn't say lucky, it's part of our preparation. And it's a given that there will be people within my community that have been trained and people within my community that I have the ability to be able to give additional training. But they're a captive audience. Right. They're there on shift, they're there at work. So, I've got them. For you to be able to get a group of people together may be a significant challenge. But then maybe you just need to nip down to the local police station and start running some BLS courses.
My biggest communication faux pas that happened with the police is I was in London and we had 2 unconscious patients from a significant assault and there weren't any ambulances and there was just me. And so I was running between the 2 patients. And the cops were being super helpful. I think they were kind of bagging or helping ventilations on one and they were helping with the other guy at the same time. And I remember scurrying between them, and I scurried over and I said, oh, okay, so where are you up to? And they said, oh, they're breathing at 14 a minute. They're doing, and I said, oh, have they got a cuff on them? And they were like, "Oh no, we haven't arrested either of these guys. These were the ones who were assaulted." Like, you idiot paramedic. And I was like, "No, like a BP cuff. Have they got a BP cuff?" And they're like, "Oh, I thought you meant like have we arrested them?" And so it really brought home that communication difference across specialties.
But then we've got a true group of internationals on this course.
Both instructor and student.
Yeah, exactly.
Yeah.
So in terms of communication, this is also good in getting everybody to speak the same language.
English.
Other than
I can't speak another language, so
but the same language in terms of the language of pre-hospital care
English.
or prolonged care.
Yeah.
You guys did conquer the world, so you get to choose the language.
It's not because I think that's the best language, but I just can't speak any other. So it would be a very short session if we did it in.
It's
like,
universal though, and it's more easily shared.
That's our excuse, isn't it?
Yes.
That being said, we had an IQ butterfly in Norwegian.
Yeah.
That went well.
Yeah.
Yep.
Once we figure out the medical words in Norwegian.
Right.
Yeah.
Right.
Yeah. But
I think between Tim and Tom, when you're talking about communicating, with your helpers, whoever they may be, BLS providers, police officers, you, Tom or Tim, you have the kind of luxury of, hey, walk through my bag, be able to practice, give me this, give me that, give me the other thing, versus Tom, who the providers have zero idea what they're doing as far as specific medical equipment. Like you said, it's more about how do you prep your gear so that somebody can very easily navigate to what you want, right? Like I said, give me the red bag, give me the color coded or numbered or something like that.
And for my guys, there's the challenge that in the UK, all our police aren't armed, but we have armed response police, and they have enhanced level of medical training. Or the fire service have enhanced medical training. So you then have the clash of they are both trained in what they want to do and their protocols, and they're very competent at it. But maybe I want to do something a bit different because I'm a doctor and I carry more drugs and I've got more options open to me. So you've got that option of, I know your protocol says to do that, and that is a good thing, but this patient needs something different. So there's that interesting clash because they are, like our armed response are very, very competent medics. So if you left them to just crack on with it, they do a really good job. But I might want to nudge care of that patient in a different direction, which is a difference from being able to say, I'm the medic on this rig and we're going to do this medical plan. I often have to negotiate you're an excellent, armed response officer. You are excellent at trauma care. But for this patient, we're going to give them some ketamine, and we all need to be on the same page, and that's the page I say we need to be on, because otherwise it's really not safe for me to do this thing.
The ones with the gun.
Yeah, which makes the negotiation even more difficult.
But then that's the nice thing about this course is we have a BLS level as well as an ALS level.
Right.
So you're arguing if you could get your cops to come in and do the BLS, they'd have a better understanding of what you do, and you would have a better understanding of what they do and their needs. Tactical medicine obviously conflicts with civilian medicine, more so in terms of a mindset than actually the medical things that need to be done. And sometimes good medicine can be bad tactics, and that's what they're looking at, and maybe the angle that they're coming from. So it's about mindsets. So we have to change the mindset of some of these students that they're used to working they're not used to having to sit on a patient for an extended period of time, and appreciating things like the necessity for nursing care, or like you with your drug counts and your extra sedative.
Because I think AEC as a course would really lend itself to being more interdisciplinary. I think if you've got some fireys and some policing at that BLS level, I think it would be really valuable for them to be like, oh, hang on, like when that doc cracks open some ketamine, maybe they need 2 minutes to go and do some drug calculations. Or when we ask them to come and sedate this delirious patient who's running in the road waving whatever they're waving, maybe that doc does need 2 minutes to work out what they're going to jag them with, rather than assuming it's all very simple. I think it would lend itself. I think it would be really interesting to do it with a broad cohort of not medics. or not healthcare professional.
But I think, Sean, you'd said about that at this moment in time, the course is more focused on a kind of a trauma type patient.
Yes.
But then maybe for us in our settings, we're seeing more medical patients.
Or a mix. You had an MI, you crashed your car, you've broken your arm, and you're still having a heart attack.
It does, it happens. Yeah.
Right.
So we're getting close to an hour now. If we can go around the horn, we'll start with you, Tom. If there was one thing that during this course your students would just have a very firm grasp of when it comes to austere emergency care, what would it be?
It would be internalizing the idea of minimum, better, best, and moving away from I've ticked that box and done that for my patient to I've done something for my patient. Can I do more for them? That would be it.
All right, perfect. Albert?
I would hope they would get the concept of do the basics well. So tomorrow we have an airway lecture that is just BVM, even though it is kind of a critical care lecture of airway. It goes really deep into the BVM concepts, and this is what I would hope these guys would have to know to be a ventilator. We have a ventilator. His name is Mike. He's right over there, and he knows the BVM so well that he knows the basics and he can be better medic.
Perfect. Tim?
I think for me, a take home is they now know that they do not have an unlimited amount of resources, and they have to become more efficient in order to manage their patients for a significant period of time, and knowing and understanding that there are phases to care that include your ruck, truck, house, and plane, and being able to make the right interventions in the right places, but understanding that there is a time to that, and being able to work to that prior to getting their patients into definitive care. That's not, what they're used to. There's a significant difference between an hour and 24 with a very sick patient.
Absolutely. Sean?
Yeah, I'll slide in here. So, I don't know, it warms my heart to hear a bunch of civilians that aren't even U.S. saying capabilities and rough truck, house plane. But the fact that you can get up and talk to them and it resonates with somebody that's working in an NGO in Africa or on an oil rig, off of northern Norway, or former military people, and then hearing the adoption of what we think are some of the best practices. But, this, to keep this in context, this is only a 40-hour continuing education course that we're delivering. We only have them for 4 days. But what I've always said is if you take smart, motivated people and you open their imaginations, you show them the context, you make them realize perhaps where they have some gaps, and then you just let them go off and do their own thing, let them get on, listen to the podcast, right? Get on the website, look at some of the clinical practice guidelines. I think that they will continue to improve their practice, but with a wider scope as to what could be, and hopefully take some of those best practices, back to wherever they normally practice and implement them. And I look forward to hearing the stories about, hey, I used, my experiences or, what piqued my interest during that course, I then went on and I was able to use. We got an email because we had sent some feedback to some of the pilot courses. And the guy replied, he's like, hey, remember that ketamine drip? I tried it with this guy with multiple, broken bones. It worked awesome. Like, thanks, guys. I mean, that's really cool because that person would have never used that or tried that beforehand. So I find that to be somewhat rewarding with, the work that you and Paul and the rest of us have done over the last 10 years. It's pretty cool to hear people that I've never met before using the same language that we've adopted. So it's all good stuff. Yeah.
Perfect. Well, thank you guys.
Yeah, absolutely, Dennis.
Thank you. Good to meet you.
Yeah, cheers.
For today's podcast, be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy is waiting there for you.